Welcome to the show where we explore how to thrive in every stage of life. I'm Alice, and today we are speaking with Dr. Parnika Saxena. Dr. Saxena is a clinical associate, professor, and board certified general and geriatric psychiatrist at Stanford Medicine. She works in the field of psychiatry and behavioral sciences and focuses on pharmacological and interventional treatments for resistant depression. Additionally, she is a big advocate for the right to patient mental health care. Dr. Saxena, thank you so much for sitting with us today.
Thank you, Alice, for that wonderful introduction.
Of course. So let's just get right into it.
Sure.
What inspired you to specialize in geriatric psychiatry, and what makes this field especially meaningful to you?
What a lovely question. I think I decided to do geriatric psychiatry shortly after I started my training in psychiatry itself. The thing I think that spoke to me the most was there's a wonderful interdisciplinary collaboration between psychiatry, neurology, and internal medicine. And this also opens the opportunity to collaborate with other clinicians in this setting. In addition, being a geriatric psychiatrist gives me the opportunity to work with social workers, psychologists, occupational therapists, and I personally really enjoy having a holistic approach when I'm working with individuals. And in addition to that, I think it's this particular population has always been near and dear to me. I get to work not with them just as a physician, but as a person. I get to learn from their wisdom of the years that they have lived and learned. It's wonderful. It's so inspiring to learn from their resilience. It's also a great honor to help people some just traverse this phase of their life, which comes with so many challenges, both mental health but also physical, and sometimes I see myself as helping them deal with the complications of being in the medical system and being a patient, and also supporting people and their families in when it's time for end of care, end of life, and it's just very thrilling to be able to work in all these different roles on any given day.
I love what you said about also learning from those older adults. I think you found the perfect field for you.
I absolutely did.
So, what are the most common mental health challenges you see in older adults, and how have they changed in recent years?
Yeah, so I think some of the most common mental health challenges that I often see are things like depression, memory loss, severe anxiety. Less commonly, I might see things, what we call as psychosis, where someone might seem paranoid for no reason, or they hear or see things that aren't quite real. And we are learning more and more that a lot of these things are caused to no small extent due to social changes that happen in this time of life. Social isolation and loneliness is becoming a global problem, and this really became an issue during the COVID pandemic. And even though now the social restrictions are probably lesser, the damage of loneliness, some of the social patterns that have changed are still wreaking havoc on people's lives, and both physical and mental health as well. And unfortunately, loneliness, social isolation, these illnesses can predispose people to being abused physically, mentally, even financially, sometimes all three. In addition, as we get older, people have physical debilities, which can also make them more prone to this kind of abuse, as well as mental health. Finally, one of the things which I don't think it's necessarily specific to geriatrics, but probably something most healthcare professionals are seeing, is the dispensation of incorrect healthcare information on social media. And not just social media, I would say the internet per se, which often leads to misinformation and might even limit people coming and seeking healthcare in a timely fashion.
When it comes to health, it's probably better to be safe than sorry.
Exactly.
How does depression in older adults present differently than in younger people?
Yeah, I think that's a really important question. Depression and also other mental health issues can present differently at different stages in life. In older adults, some of the things that are probably a little bit unique are one, we often see memory issues present with depression. That is not always the case in younger folks. We also tend to see pretty significant changes in their ability to function. And by that, what I mean is, again, day to day activities, right? Like eating, drinking. We often see what clinically we call as a failure to thrive, which means just difficulty living life or surviving. And sometimes it can be so bad that a person needs to come to the hospital. And often, not often, but quite a few times, that can be due to depression. And then sometimes, instead of seeing your classic sadness, hopelessness, or helplessness, you might see that the person is more withdrawn. They don't talk to their family as much as they did. Or they might seem just more apathetic. So let's say you're all doing something together, like watching a show which this person always liked. You just see they don't respond as much. They seem really distant or cut off or remote. So those are some things that can be uniquely different in older adults. People can also have symptoms of what we call as a thought disorder, which means that their thinking just seems off. So this can range from what seems like, full-blown paranoia, feeling like someone's out to get them, someone's trying to steal from them, someone's plotting to kill them. But it can also be more subtle, like just believing something is physically terribly wrong, and you've gotten all the workup done and everything's okay. Or sometimes you can just have these very fixed ideas about things that as a family member or caregiver, that this is not reality based. So those are some things that as geriatricians we see more commonly in older adult depression.
There is some stigma surrounding things like ECT as well as TMS, especially probably among older adults. What can you tell us about this?
Yeah, so I am myself, for full disclosure, I perform electroconvulsive treatment here at Stanford. I'm a trained ECT physician, and this is a treatment that's available in several different medical centers, not just within the US but throughout the world. It is the oldest treatment available. Really for any kind of especially severe or treatment resistant psychiatric disorders. It especially works very well for treatment resistant depression. I think one of the things that has really caused it to be maligned is probably, I think historically there has been some issues with the way it was probably dispensed, and unfortunately, to no small extent, it's also the way it has been represented in the media, in certain movies. One of the things that I often see is that when we have somebody who really is very, very unwell and nothing has worked and need ECT, the stigma is the biggest barrier to them getting the treatment. And that is not just my anecdotal experience. This is very well documented in multiple research papers as well. The thing that I would like to tell any of your viewers or listeners out there is that whole idea, I'd like to reference one flew over the cuckoo's nest, because that's often what people tell me they think about, is this idea that you're doing it because you want to silence someone and you do it without anesthesia. That is not how we do it. The way we do it now is that people get general anesthesia, which lasts for like 3 to 5 minutes. We give, so they go to sleep, and then we give them a muscle relaxant which relaxes their entire body, and then we give a very brief electrical impulse which lasts for anywhere between 5 to 7 seconds, which produces both a physical seizure and then an electrical seizure, which we monitor using EEGs, which you use to monitor seizures. Literally the only movement that's going to happen is just the tap of your foot like this. That's all. You're not shaking, because we don't want to hurt you when we do it. And then, this seizure this doesn't go on for longer than 2 minutes. So the whole procedure happens in under 5 minutes, and then people wake up within 15 to 20 minutes. It's a very quick procedure and has some of the best rates. I can't tell you how many people I've known who've had a dramatic improvement in their illness and are fully functional. I know a lot of people worry about memory. That's one of the big fears. If it helps, it's actually one of the treatments for people with severe dementia who have really bad behavioral issues, which can happen, and it doesn't, quote, worsen the dementia. There's actually good evidence. So if we are using it for dementia, it's obviously not going to worsen memory. What it can do is during the, when you're getting it more frequently, which you have to do in the initial phase, people can have some memory issues initially. And then once you start to taper it off, the memory issues do subside. We have a very small handful of people who've been getting it for years, and most of them don't really report any major memory disorders. In fact, having untreated depression, especially as an older adult, is a much greater risk factor for having memory problems than a treatment like ECT. So it's a very safe, I'm not saying it's 100% safe. Nothing is 100% safe. There's no medication, nothing that's 100% safe. But it is a lot safer than a lot of other procedures people worry about. And actually, it's one of the few things that in older adults, it's actually better tolerated. And if you look at the evidence, older adults have less memory problems than even younger folks do. And if you think about, like, if you're really sick, you need sometimes a lot of different medications. If you think about the cumulative effect of all those medications, the side effect profile, and if you look at a comparison between that and ECT, a lot of the times ECT ends up being the safer option than being on 3 or 4 medications at the same time. I know it's not always available, but if it is, it's definitely something to strongly consider when someone is not doing well and not responding.
Thank you for sharing such important information. Can you please share an impactful patient story, whether related to dementia or depression, where treatment restored hope?
Yeah. If you don't mind me, and again, I'm not trying to champion ECT, it's just one of the most, it's just like I said, it gives me some of the most remarkable transformations. I've had quite a few patients, and I remember one specifically where there was a gentleman who had, he was in his 80s, and he had depression mostly after, he got older, like after the age of 70. And he was older. He had some physical health issues for which he was in like an assisted living, which means he wasn't in a nursing home, but he needed a little bit of support to get around. And he had become very profoundly depressed to the point that he wasn't even able to think straight, which is something we see, like people are not able to make decisions because the depression just like has such a strong hold on you. He wasn't eating, he had lost a lot of weight. He just kept talking about how he didn't want to be alive anymore, and he had tried a lot of medications. The other problem was, because of certain health issues, some medications which could have really been helpful were not an option. And we talked about ECT because, like I said, sometimes ECT is actually safer than certain medications can be. And we, just like a lot of people who've never really heard about it or seen somebody who's gotten it, he didn't really want to get it, or not, he didn't want to get it. He was apprehensive, as was his family, and we had a lot of conversations, a lot of education, gave them a lot of information, and they, because nothing was, and we tried medications as much as we could, and literally within a few treatments, he was a completely different person. His son said, even though his son had brought him in because of a decline over a year, his son said he looked as well as he did like 10 years ago. And he left from our hospital. He had a little bit of decline because he had not been moving. So he went to a rehab just to physically get stronger. And usually when we do the treatment, we recommend it for 6 months, and then that's it. You don't have to do it for the rest of your life. And the entire 6 months that we followed with him, even after he left the hospital, he was doing very well. And as far as I know, he not only went back to his assisted living, he was actually taking care of his own wife who had dementia. Oh, wow. So he went from not just needing to be cared for, but became a caregiver himself very successfully.
That's incredible. How do you see technology such as telepsychiatry, cognitive monitoring, and digital tools shaping the future of mental health care for aging populations?
I think these tools are going to play such a big role, and they already are, especially in the older adult population. And I think this became really apparent during COVID because one of the big things that happened, I would say one of the silver linings, was that telemedicine became reimbursed by all insurances, at least in the United States. So it became much more accessible. And because of that, a lot of people who really live very far away from, not just even geriatric psychiatrists, but just psychiatrists, primary care doctors, were able to get the care which they hadn't been able to get for a long time. And not just a one-time care, but consistent care, which is very important for most people after a certain age. So telemedicine has played a huge role. It has I saw myself when I was a psychiatrist and COVID hit, my no shows went down by 40%, and most of these were people who were not able to come to the office because the person who was going to give them a ride was not there, because their child who was going to give them a ride was busy at work. Okay, I mean there are lots of reasons people are not able to come, and that went down to almost like negligible.
Wow.
Just because they had telemedicine, we could pick up the phone and talk, or we could do video appointments. In addition to that, there have been a lot of digital tools that are being used. So some of the tools that are being used are apps, for example. Some of the most common things that people really struggle with are things like insomnia, what we call as behavioral activation, which means that once the depression starts to lift, to get back into the swing of things, right? So that because when you're depressed, it's very hard to do things. But once the medications kick in, even though people get some energy, some of those behaviors of depression can remain really entrenched, and it's hard to get up, have a routine, do things that'll make you feel happy, that'll make you feel good. So now there are some great apps that help with that. There's some great apps that actually do what we call as cognitive behavior therapy for insomnia, which can be so helpful for people with long-term chronic insomnia. So I personally actually have a lot of patients use that, and it has been so beneficial. AI, artificial intelligence, machine learning is also being used. I would say it's in infancy, but it's really helpful for data monitoring. So one of the things that is really difficult sometimes as a psychiatrist is when I see someone, sure, let's say they're having a good day today, but how about if in the last month, the first 2 weeks they had a really hard time, but then the last 2 weeks they were feeling fine. It's important for me to know as a psychiatrist that those first 2 weeks were not good, but people might often not remember, or when you're feeling well, that might just feel like, oh, that wasn't too bad. Data monitoring through some of these apps, through AI, can be really helpful because it gives us a much richer snapshot, and really gives us more evidence to be able to help people better, not just in the moment, but also long term.
Do you happen to have any of those apps you mentioned, such as for insomnia?
Mm-hmm.
Do you have any that you could recommend?
Yeah, there's a VA app for insomnia. I think it's called VA CBTI, something of that nature. It's a free app. So that's really helpful. There's an app called Calm, which has both a subscription and non-subscription service, which can really help for sleep as well. Those are some of the common ones that my patients usually like to use and have found helpful and user-friendly.
That's incredibly informative. Let's talk a little bit about caregivers now. How can caregivers supporting their older loved ones better take care of themselves?
That's such an important question. As a geriatric psychiatrist, especially when I work with someone who has a caregiver or a close family member who functions as a caregiver, I see my job as not only supporting my patient, but also supporting the caregiver. Because if the caregiver is burnt out, it's going to affect the care of the individual I'm taking care of. So it's really a unit. And I'm pretty sure all geriatricians look at these kind of treatments that way, look at care that way. I wish there was one single answer that I could give that would address this. What I would say is, number one, to try and remember as much as possible that a lot of the times you really need a village. One person might not be able to take care of everything, which means that utilize a doctor, utilize other caregivers if possible at some point, because a lot of the times the caregivers are there for things like dementia, which unfortunately, in a lot of cases, not all cases, but a lot of cases, can be progressive. And when dementia becomes more progressive, the problem that comes about are that there can be more behavioral disturbances that we were talking about. So sometimes that might mean that one caregiver is not enough. Sometimes that might mean that maybe even living at home with the caregiver is not a safe option anymore. A person might be better served being in a facility, like an assisted living or a nursing home or a dementia care. There's so many different levels. So I think the things that I would say is, number one, be mindful of when it's taking a burden on you. Getting burnt out is not going to help you. It's not going to help the other person also, because this is not a short-term thing. It's going to be a long-term thing. Number two, There are lots of caregiver support groups, through different organizations like Alzheimer's Association. Our clinic on occasion has caregiver support groups as well. Lots of different medical centers have caregiver support groups. I often check in with my patients' caregivers, especially when I see them getting burnt out or even depressed. I tell them, do you have your own doctor? Do you have your own therapist? But also remembering that it is not fully incumbent on you to fix what's going on with them. They have probably a disease that's going to get worse. And you need to have that support, and you need to take care of yourself. And I know that it's easy to say it, it's not always easy to get that support, but the first thing that's important to do is to not bear the responsibility all by yourself. Remember that if you're not able to do it, it's not your failure. It's not meant to be done by one person. It's usually this responsibility is meant to be divided amongst different people. And also remember, whoever you're caregiving with, a lot of people who you're caregiving for or the caregivers themselves might develop depression. One of the worst things about depression is that depression makes you feel that there's no hope, even when there is. That's one of the worst things about depression as a chronic illness. So even when you feel that way, remember that there are a lot of treatments, there is a lot of support, so make sure you get that support.
I really do hope the caretakers at home are listening to that information. As we wrap up, what gives you the most hope for the future of aging and mental health?
I think the thing that gives me a lot of hope is seeing this become a more talked about topic. More and more people are becoming aware of it. I see, especially when I meet with let's say if I go to some kind of a social gathering, whether it's people my age, people who are older, there's a lot more awareness that they need to take care of their health so that they can age successfully. I think the focus on successful aging is a great one. I know a few years ago, one of the Surgeon Generals talked about loneliness being a major health, public health issue, not just in the US, but also in other countries. I know the UK has a Ministry of Loneliness. I think what's wonderful is that we are talking about things in a preventative fashion. That's what we need to do. We are here as physicians to treat, which is great, but the more we can prevent and allow for successful aging, the better. I think it's also great that I'm seeing a shift in the mindset where people used to think, if you're older, that's it. You're not of any value to society. And I'm seeing that mindset change in a lot of people, which is great, because as people get older, just because they're not working, because they're not maybe, their children are older now, it doesn't mean that they're not of any value to society. Their wisdom, their historical memory of what they have done to bring civilization to this point, all of these things are so important, and these are important. They're important pillars for successful society. So I think my biggest thing is seeing the focus on successful aging is what makes me really hopeful.
Yes, and like you said earlier, older adults inspire you just as much as you can help them, right?
Exactly, yeah.
So Dr. Saxena, thank you so much for giving us so much to think about and so much hope. Where can people find more information about you and your work, as well as about geriatric psychiatry more generally?
Yeah, so there are quite a few resources. Some community resources include the Alzheimer's Association, which has a great fund of resources, especially when someone's struggling with dementia and for their caregivers. The National Alliance of Mental Illness, NAMI, also has a website which has a lot of information on how to deal with mental illness. There's another organization called the American Association of Geriatric Psychiatry, which is an association for physicians, but also for the general public to get information about caregivers. I believe they also have a portal for geriatric psychiatrists who are taking patients, so that can be a way sometimes to seek help. My work is primarily on my Stanford website, which has the most amount of information about the work I'm doing.
Wonderful. Well, we have reached the end of today's episode. Thank you so much for joining us.
Thank you for having me.
Thank you also for giving us such crucial information surrounding depression and dementia treatment in older adults.
Absolutely.
To our audience, thank you for watching. I hope today has equipped you with some practical knowledge and inspires you to continue to learn about and seek treatment. I'm Alice, and until next time, stay well and take care of yourself and each other.
Bye.